Welcome.
The Pathology Innovation Collaborative Community is a regulatory science initiative that aims to facilitate innovations in pathology, as well as advance safety and effectiveness evaluation. The PI Collaborative Community aims to harmonise approaches to speed delivery to patients through collaboration in the pre-competitive space. The PI CC is open to all stakeholders, public or private, including but not limited to academia, industry, healthcare providers, patients, and advocacy groups. Meetings of this kind are an example of lawful activity under federal antitrust law, because the focus of the meeting is on government action or policy, including the industry's responses or positions taken with respect thereto. However, antitrust monitoring is needed for companies' own protection, since they are direct competitors meeting together. These meetings need to stay within protected subject matters and need to be monitored so that they do not stray off into inappropriate areas, such as pricing and price terms, sales and service territories for particular products, customers and customer territories, each company's individual decisions regarding selection of suppliers or customers, marketing plans and especially future marketing plans or new product offerings, other proprietary or competitively sensitive information. Today's meeting will follow the written agenda, and there will be no discussion of pricing or other prohibited topics. If the discussion veers into those topics, we will terminate the discussion. If you have any questions or concerns about the propriety of the discussion, please raise it immediately, and we will take a break to determine how best to proceed. The Medical Device Innovation Consortium acts as the formal convener, and we will follow their conflict of interest policy. For additional information, we defer to our Code of Conduct and our website, www.pathologyinnovationcc.org. We look forward to moving the field forward.
All right, welcome everyone. Thanks for joining this lovely morning in the second session about the so-called CLIA waiver, which is not really a waiver, but a question on how to continue what's currently an enforcement discretion for remote review in pathology. In the second session today, we wanted to talk about some of the practical consequences that have already happened and, basically just talking about the various practices and enabling everyone to ask questions. For those who haven't been at the first session, I wanted to briefly provide sort of a quick reminder of the breadth or broadness of this so-called waiver or enforcement discretion. So this affects everything, not just digital pathology. And we put together this little diagram here. I hope you can see this, which is, it affects pathology laboratory medicine. And if you go all the way down to remote, sign out, there can be roughly like 4 bins. One is just to sign out cases remotely, meaning logging into your LIMS system as a VPN, for example, as an example. There's reviewing cases remotely, which is kind of like taking slides home and doing home screening. It may or may not involve signing out. It may just be a remote practice of previewing your slides for the next day. There's of course the use of digital pathology in a CLIA lab, which could be primary review. I think that's what many people call it. Or there's the fourth option, which is using digital pathology remotely for primary sign out. So there's a whole gradient or array of options on how to use this sort of setting. And to really get sort of an idea of what people have done during the pandemic, I thought it would be great to discuss this today in terms of, what are you doing? How did you validate this? And, the current enforcement discretion, of course, entails numerous points, what you have to do to enable this. But I just wanted to provide this as like, a quick 1-minute reminder that this may entail, people who sign out their flow cytometry remotely, and it's not necessarily restricted to just digital pathology. I just wanted to make that like quick opening statement. And I'm very glad that so many of you have joined, and I'm very curious to learn what you have done in your various settings and whether it has empowered you, and if you're willing to share also some of the struggles or challenges, that would be great. Again, good morning.
Uh, Morning. My name is Mehrash Hagigi. I'm from Mount Sinai. We started implementing digital pathology for primary diagnosis December 2019. So we are scanning a majority of our slides, maybe 2,500 slides per day. Many of, obviously, during pandemic, many of our pathologists, they were interested in signing out remotely. And we are thinking about kind of continuing the same practice. It was very smooth, it went very smooth, no problem. However, we are specific, the only way that we are doing it with the VPN and remotely getting into the, and I can think of the last option that you introduced. I can think of like how would they sign out the cases, even if they can remove, I understand you can get access to IMS, image management system, and review the digital pathology, whole slide images. However, getting into lab information system and signing out the cases, finalizing the cases, that would be a different story. So I'm interested in knowing about that option, if any institution using that last option, or if you could provide more explanation about that. But we are mainly using VPN if our pathologists decide to sign out cases remotely.
And do you mind explaining, so you scan the slides in your, let's say, Mount Sinai proper CLIA environment, and the slides are served, let's say, through a server or shared file drive, and the viewers are on the local computers at Mount Sinai. You VPN in, you perform digital review over screen, and you log into your LIMS system, and you basically remote review and remote create report and remote sign out.
So if they are at the location, so we have 8 affiliated hospitals. If they are at the hospital, affiliated hospital, they're in their offices, they don't need to VPN. They just log into the system regular. We created like hyperlink of the thumbnail in the LIS. They can see thumbnail of digital pathology. It's already linked to that case.
So that would be this, right?
The first one. Oh, so yeah, exactly, the third one. But however, during pandemic, maybe very few of our pathologists, they were using the option, the first option to the left, signing out cases remotely, the orange one. And basically, that's, and even if we decide that we want to continue, if the waiver goes through, we're gonna like follow that kind of model. The
So
last one,
yeah,
the gray one,
maybe
I don't know
maybe just
how.
for explanation, what I mean, this is obviously not a perfect rubric. That's why we're having these discussions.
So the
This would
first,
also mean if you drafted a report in your LIMS system and you would VPN in from home, right? Like you reviewed on a microscope, you drafted a report. Let's say you have 50 reports in your queue. This could be remote sign out, just where you log in to remotely
yes,
VPN. This doesn't have to contain any digital pathology, right?
that's correct. But however, what I'm saying, if our pathologists, sometimes they sign out from from home, they're not at the hospitals. They're at home. They log in VPN to their cases, to the system inside the firewall. They have access to digital pathology and LIS, and they finalize their cases. And you're
Perfect.
right.
So
But
this
however,
would
in our case, they use the whole slide images.
so it would be in a way a combination between these two. So you have
Uh,
primary review.
Um,
You yeah.
I think because I'm Mirvash, I think we've talked before about the thing. I think you're using digital for the folks that are signing out at home. There are actually some practices out there. I remember I knew somebody from UCSF who they were shipping slides because they didn't necessarily have the
oh,
big
okay.
and so
That's
if
what I was trying to understand. Yeah, okay.
yeah,
I
so that's
missed the first session.
so there are two frameworks. There are some groups that don't have the digital capabilities, but the remote sign out was not just for digital, it was for everything. And so that's why we put these bins in there. So for
Makes
those that are
sense.
using physical glass slides and have an SOP, which I believe UCSF did, and there are other practices that did, that signing out remotely was possible based on their framework of shipping physical glass slides. But the VPN example is relevant for both because the LIS still requires a VPN. As far as I know, there's not really a separate way to do it to get to all of our LISs. So VPN is still going to be there. And that also creates some constraints operationally because our VPN, it kind of drops a lot and slows down, but it's still it's still usable. It was one of the biggest complaints across the hospital. The VPN kept dropping. So they've actually beefed it up quite a bit just so that people can do telemedicine. So VPN, enterprise-wide, a robust VPN ends up being very crucial for all of these.
Right. So we fortunately we don't have that problem with VPN, and personally, I can get connected, stay connected to the VPN for 10 hours maybe and get a lot done. But okay, so we are using digital pathology, just to clarify. We are using whole slide
One on the
images.
right. It's the far box on the right.
And yeah, and the third one at the location. So
Well, one other thing about the VPN too that we've noticed, and maybe you don't have that problem at Mount Sinai, is that it throttles. So the throttling can drop our VPN speeds down. I knew when I was doing mine, and I'll put in the literature. Matt, I credit Matt, actually, he was first author in pretty much most of these, but
I can imagine it can be very, very frustrated. We had that
slow.
problem 2 years ago, but it's resolved, and I don't know how they did it, but
yeah, but the VPN speeds that you need don't necessarily have to be super high. Like I've checked some of the VPN speeds going, if you're getting above 40, it's okay. I mean, but I've seen the VPNs actually drop it down to below 10, and that ends up being pretty problematic. Obviously, you can't hold Zoom calls and other things, but at 40, without doing Zoom and other things, you can still get by. So that's some stuff that's not in the literature, but just out of personal experience, we're really messing with it. That you can tolerate not necessarily the highest bandwidth and still be able to get by.
very good.
Yeah, so one question, of course, related to the, let's call it the way that this would need to be validated, correct? So, I mean, of course, in your use case, Mervash, the slides remain at the primary location, so I presume you still keep, standard retention requirements. So, then obviously one of the question is, let's say the enforcement discretion would be discontinued. How would we say establish and verify the performance specifications? Because I presume you obtained data from people. For example, are you aware whether someone signed a case out remotely or not? Would that be possible to
Oh, that's a
reconstruct that?
very good question. No, if they, unless they sign out after hours, like 9 o'clock at night. So it's very unlikely that they would be at the location when they sign out. But other than that, and then physically people like they kind of, when they go to work 8 to 5, we kind of know there are affiliated hospitals, there is 1 or 2 pathologists, but basically they have to be present at the location. But no, we don't have like tracking system in place to know.
This is something that's been a problem for us too.
Okay.
Our QI committee has asked if we document it, and you can see how well that goes when everybody has to put a copy paste. We signed it out at home. We're already pretty pissed off. We have to do a lot of work. But
we wanted to do that, but then I reached out to a few colleagues and they said that we don't think it's necessary, because we wanted to put a disclaimer saying that this as the case has been signed out using digital pathology, and they're saying you don't do that when you're looking at the glasses slide. Well, what should you do it when you use digital pathology? So people had different approaches. I don't know. Yeah. So you are using that disclaimer, Joe?
No, that didn't go well. I mean, anything that you have to do some extra manual documentation, you know how well that goes with people with just documenting.
But that's a very good question. So
No,
tracking,
actually,
tracking who's signing out remotely and who's signing. That's a very good point.
So this is what we're doing right now. We're working on some work behind the scenes on the back end, so that the viewer systems, and it depends on your view. I doubt Philips has the capability to do that. But we can sort of track on the back end if the viewers popped open, if certain slides are looked in within a certain time period from scanning. So we're sort of building these rough algorithms to be able to do that. We don't necessarily document it in the report, but we are able to sort of know by if the image is being pulled within a certain time frame, and how many images at a certain threshold. We sort of make the assumption, like if you pull 5 of them, we sort of make the assumption, right after they've been scanned, and then we sort of make the assumption that it's digital sign out, even though they may have not done it. Maybe the slides have physically made it to somebody's box, but we sort of made that model to make the assumption that it's digital sign out. And from that standpoint, this is a rough way that we gauge it. But documentation, we haven't really figured that part out either, because as I don't know.
So yeah, to answer your question, we are using Philips, and as far as I know, Philips doesn't have that, doesn't provide that capability. So we don't have that information.
So the whatever happens, of course, is hard to predict, but we have to work under the best and, of course, the worst assumption. So since many of us have done remote sign out during this public health emergency, we have the data, and I presume one of the big efforts would be to centralize that and see whether there's non-inferiority, right? That's what it comes down to. Documenting that is a completely different thing, because that's so much extra effort. And I mean, one of the points was that this enforcement discretion was put in place to prevent harm, right? Like to people who, wouldn't be safe to go to work, but also to sustain current diagnostic practice. So in hindsight, going back and trying to figure out, was there non-inferiority? I think many people have done some remote sign out in one way or another. So this is probably the evidence when it comes to, let's say regulatory science input, to say, look, we have had 500 practices signing out 10,000 cases, and there was no substantial difference. But the question is, of course, how to demonstrate that. But that was just the reason. So the documentation is one of the requirements under those statutes, but of course everyone understands that that's not easily possible.
Yeah, and I did put our experience with the remote sign out, and sort of gives you the rundown. I think it's maybe the second attachment I put in there. And just as in a summary, the monitors didn't, that was a surprise to me, that monitors didn't matter, so for those that really want barcode monitors and say it's going to destroy practice, you really don't. People were really signing out with some rudimentary stuff. They weren't doing it on iWatches, which is something I always tell the joke, but 13-inch monitors, nothing very fancy, and it seemed to work. So the bar in terms of being able to sign out, it's not comfortable. I've done it on small little things, but you can do it. And it didn't diminish anything in terms of the quality.
So I haven't read your study, and I'm going to review it. I don't know much about it. However, I should say that in our experience, we notice, and I don't know what type of cases you
Everything.
evaluate.
A lot of GU. Obviously, the person has the most is me. So on this study, but heavy GU, some breast, pretty much the subspecialties. I think everybody got representative.
Mm-hmm. So that's one area that I feel like even if we want to waive the CLIA requirement, maybe not all the criteria that FDA has come up with monitors, not necessarily some of them should stay in place. It depends. So, but I should read your study. But we notice differences. Like obviously, I mean, there are certain factors might be more important than others. Like, how do you feel about the resolution of the monitor?
It didn't really make a difference. I mean, people were still being able to diagnose.
So,
consumer grade stuff.
Did you do a validation of
This is our
those
validation.
different monitors?
This was our validation. We used
Okay.
the data to LDT our sign out, remote sign out for New York State. So this actually paper was used for Matt and Anna to submit as an LDT to New York State.
Okay, that makes sense.
So one thing, being able to, I may disagree with you respectfully. Like one thing is to be able to sign out something or diagnose, and one thing is like the differences, minor. Might not be that significant. However, it matters. For example, I noticed for HER2 grading, for ERPR, When they use it on regular monitor, they are, might not be, but 1 degree, 1 plus, you can see that difference. So,
That's a
but
fair
I'm
point.
very interested, and I'm going to read your study for sure.
That's a fair point. I should point that out because I always point out biases, and I'll point out our bias. Our bias is on H&E diagnoses. We didn't really use it for IHC grading. So your point about biomarkers and recognizing granularity, and that it was not within the scope, at least, you know, that was probably, if it was included, as a very small minor. And the way we did our metrics was on diagnoses. So how do we fill out the pathology report? But the ERP here was not part of it. So our study did not cover that.
So, but I agree. I mean, there are different factors. If, for example, during pandemic, it makes sense that you want to take care of patients. You don't want to postpone diagnosis because using with whatever monitor you have using digital pathology, it makes sense. However, if there's not any like critical situation, maybe we should follow the best practices or like consider like certain details. So, and in the when it comes to monitor, for example, one other thing that I noticed was the size. So the size of monitor matters as well. Did you, again, I have to read your study, Joe.
Like I said, 13 people were, I think it's a case of, are people comfortable? No, they weren't happy about it, but it sure beat going in the office. Now, that's a different constraint when you have choice.
So I think that's a very good area to do research on. But however, like there should be a balance on not risking patient care and providing a high quality versus other factors. But I can understand.
Yeah, I think you should read it because actually the point of the paper was that at 13 inches, we didn't diminish, at least on the diagnostic quality. We didn't do something on the biomarkers, but it didn't affect the diagnostic quality. And so that's the argument. So when push comes to shove, you can do it.
I have to read it. And then I've done this sort of validation, and there were questions like certain subspecialty, they had certain concerns. When it comes to the details, like breast, they were worried about ADH versus cancer, microinvasive versus invasive, the resection of head and neck. When we validate, we notice minor differences. I don't have the data to pull it out right now, pull it up, but I can provide you like, so yeah, here and there are certain details that.
And I think this speaks to the fact, and I think Joe can agree, that there needs to be local validation. Just because we did it doesn't necessarily mean that it works in every practice. So,
and I'm very interested to review it.
So I'll just say quickly, so for the monitor size issue, it's not I would say it's not necessarily so relevant to diagnostic quality. You will still have to validate regardless what you have. I think the size and resolution will mostly relate to the efficiency. The more pixels and higher the resolution on the screen, the more tissue will fit on the viewer. So I think it'll mostly relate to efficiency, but I think regardless, you'll have to validate your end-to-end workflow within your organization. And if possible, I think it would be great, especially considering, so the way we framed our LDT that New York State approved, we ultimately said as long as the scanned image is as high fidelity, is representative of what's on the glass slide. So from a QC standpoint, from a technical standpoint, the concordance is really just supporting documentation. It's supporting evidence that the scanning, the digitization process worked, right? Because in theory, if the digital slide has everything and all of the qualities that you can view an image on an image as the glass, the pathologist can be taken out of this kind of I don't want to say validation process, but taken out of this diagnostic process, because there would be no differences. And in times where there were minor discordances, we found that those diagnostic qualities were still found on the digital image. It's just for whatever reason they weren't reported, or some of these are academic differences in report and things that we know have pathology subjectivity. So I think understanding this from a technical standpoint may help, but at the end of the day, CLIA as a governing body, it will have to make some sort of determination at some point. But at least from the New York State standpoint and what we were able to get approved, we did a lot of technical QC and proving that the digitization process worked, and the concordance data, diagnostic concordance data, was more of supporting evidence.
So the fact, I agree with you, the size specifically for a standard size that has been suggested in FDA, making it much easier to navigate the slides. So what I'm saying, there might be some dire situation that you might end up using like non-standard monitor, but I don't recommend it becomes regular practice or routine practice or best practice. It shouldn't be that way. The fact that navigation in a certain size of monitors is easier affects the pathologist fatigue. So that's an important factor as well. And if they have a hard time to go through the slide using a smaller monitor, it's not just a matter of being diagnosed, I mean, end up if it's cancer. So having the same diagnosis, the details of diagnosis and the grades, and those are important in treatment as well. So it's one thing to consider the final diagnosis, so atypical, benign, malignant. Okay, just the top line might be the same, but then it comes to the details. And the fact that navigation might be easier on certain size of the monitor, bottom line is going to affect pathologist performance in terms of diagnosis, and might affect their interpretation as well. So
I mean, there's
I
other
might have
things.
to, yeah, I might have to a little bit, I think we should be more cautious. That's all I'm saying.
I think
But
the
I
point is,
understand that's a valid point you have. It's doable, but it doesn't mean because it's doable, we have to do it as a routine practice.
I think that the point about, I don't think our point was, I'm sure it's not our point is to go to the lowest common denominator. I think our point was that you don't need the highest end barcode monitors at all. We proved the minimal amount, but like I said, it wasn't comfortable. I think all of us would demand something better, but we don't necessarily need to spend 10K or more on a monitor because that's not necessary. That's really the main thrust of this. And I think that expands the pool for adoption. If you restrict the cost with just 10K barcode monitors, that ends up being a problem. We've been able to show that you don't necessarily need that.
Harsh,
So if I may
sorry,
interject something.
Meftash, sorry. Harsh
Sure.
raised his hand. Sorry.
Yeah, thank you. Thank you. I see that Richard Torres also brought up the same issue I wanted to. I see Dr. Belize is not on the call, so I will echo what he said in the first call. Really, a lot of these issues about is this resolution, is this image sufficient for me to make a diagnosis comes down to pathologist judgment. We don't regulate which microscope a pathologist can make a diagnosis. Over at Mount Sinai, when I was there, the Dr. Strauchen, the legendary hematopathologist and surgical pathologist, had this ancient microscope, and everyone brought their difficult slides to him, and it worked. So I'm not advocating for the lowest resolution monitor, but I am saying that we really need to. I would suggest that we recognize that it is up to the pathologist at the end of the day. When I'm signing out cases, if I see fallopian tubes and I can see that there's a complete cross section, that particular case is okay to sign out using even my little iPhone. However, if it is a very difficult diagnostically challenging case, and sure, pathologist fatigue is an important issue, but I don't think we should at least allow, when we make recommendations, we should allow for some opportunity for the pathologists to make their own professional judgment about whether or not something is appropriate to make a diagnosis. At UTMB, we faced this decision about whether to buy those $10,000 monitors or not. And then at the end of the day, we decided we were going to use the slightly higher resolution monitors from Dell that cost like $400 each. So our primary validation was not, we bought those two Philips monitors, put them to the side. All of our validation was using those Dell monitors. So it's like an LDT. And someone talked about the speed and the bandwidth. We faced this one issue when we were doing the sign out. We wanted to make sure we could sign out using Citrix. So our LIS is in Citrix. And the link from the LIS takes us to the IMS viewer. And the argument from Philips was, well, that's not what was FDA approved, that there wasn't a Citrix component in our FDA validation. So we said, well, we are anyway doing it essentially like an LDT. There was this discussion about the lossy versus non-lossy transmission. And so there is an option in Citrix to turn off and make it a completely lossless account. We didn't even have to do that because we saw that there really wasn't a practical difference. Sure, can I see H. pylori on my digital images? No, the glass slide and the authentic microscope is generally a lot easier, but I know if I have chronic inflammation and activity, I'm going to order that immunostain. So again, comes down to me, if I make a mistake, I'm not going to be able to blame my microscope or my digital image. It's on me. And so if we are taking the liability, I think we should be given the latitude to make that professional judgment. That's my opinion.
I think that's a very good point. What Matthew just said earlier, I think resonates with that. Because if you see a slide, let's say a gastric biopsy with 6 pieces, but the scan only registered 5, and you don't have an overview snapshot of the whole slide, you may not even know that you're not looking at everything, right? Mm-hmm. So I think that's more a process of, let's say, the digitization part in the lab. Yep. But if you specify, let's say that you can scan the whole slide and you have evidence that you have all the material and everything's in focus and of good quality, I totally second that. But, currently that part is also not restricted by CLIA. Right, like mm-hmm. there's no. I mean, I think right. I don't know who put this. I think Richard put it in the chat. That part is not really regulated, but you have to document that your procedure, in your procedure manual or your SOPs, is very well established. How you ascertain that whatever is served up digitally is complete. I think that right. that part is what I think one of the key issues is.
Agreed.
So the problem with digital pathology is that most of these technical impact, the monitor specification that can impact the quality of image is technical. So pathologists, they're not able to recognize that. What I'm saying, FDA, when they approve like certain setting or specifications for monitors, most of them are engineers, and I'm hoping that they would know the background of the monitor, the devices and everything. There are multiple factors that are important. It has happened. So what you're saying, Dr. Tucker, it would be the case that pathologists, if they would, whatever they sign out digital pathology with whole slide images, they should be able to look at the glass slide and then compare. Otherwise, they wouldn't even realize if they miss something. In our case, what happened when I went back and there was completely different thing. I looked at the ER, PR, and I took it to the our pathologist. She didn't even know that there was that difference of like one plus 1 or 2, rare cases too. But between her interpretation from digital versus glass slide, she didn't even know. She wasn't aware. So knowing if trusting that, okay, the digital pathology, the image quality that I have is good. We are talking about the details of it. In your eye, I mean, I'm not talking about missing tissue or something is biliary that you cannot see through it. Obviously, those pathologists would realize right away. I'm talking about between scene 2 versus scene 1, invasive, micro-invasive versus invasive, grading of certain tumors, the details of it. And I feel like we shouldn't, I'm very open to maybe waive some of the specification that the FDA has provided. And I agree that some of them might be like too much. However, I'm hoping we shouldn't compromise we are very detail-oriented pathologists. We are very pay attention to the details of the things. That's the specification, a strong point of our practice, and I'm hoping we wouldn't compromise that. In terms of the price, if we are hoping to cut the price of the adoption, so it's not only it doesn't have to be medical grade. FDA has also provided other like a list of monitors that can be used, and some of them are quite cheap. You agree, Joe? I
That
don't know
is
if you have
exactly
seen.
yeah, they
that is
do.
exactly the one we are using. So we asked
Yeah,
Philips
okay,
to
so
tell
I
us
agree
to give
with
us the
those.
list. We asked Philips to give us the list of all the monitors
Yeah.
that they recommend, and we used one of the ones. Unfortunately, well, you know, they went through the FDA process several years ago. Today's monitors, actually Dell and many of the manufacturers have updated their monitors so that, in fact, the FDA recommended monitors are not that great. You can go today to, you know, to your local Best Buy and buy a far higher resolution.
So
it's not even a 4K, the
Harsh,
Arthur monitor.
I can second that, but let's talk about regulation. Even if you buy an FDA monitor, that will not free you up from the need to
Self-validate.
demonstrate performance and
Absolutely.
specify how good you are.
Yep.
The monitor discussion is I would call it a specific and nuanced point where you can assume we even went for the FDA monitor. But, you know, if you operate that tired, of course, you know, you have to specify what your performance measurements are, be it a Dell monitor or a Sony monitor or an FDA approved monitor. So I think what we're currently trying to establish is, under the current enforcement discretion, the specific section that CLIA, in this case through CMS, refers to is this particular paragraph, 493.1253, which is one of the 5 requirements. So just to zoom out, this is available on our project site. So among the numerous things that you have to under 1251 under your procedure manual is, you know, that the test system has to be established or verified following this, you know, federal code. And that federal code is what I believe, you know, MSK has published in excruciating detail in numerous papers, which is, when is it applicable? How did you verify your performance specifications? How did you establish that, you know, using the traditional performance metrics? How did you determine your control procedures, for example, that the tissue is intact? And how did you document that? So that's basically ABC. That's the ABCs of what every lab has to do right now. So that is the part where there's no CLIA certificate needed. You don't have to have your home office approved. You don't have to have an inspection by the Department of Public Health in your jurisdiction. But they defer to this and say you have to fulfill a couple of things. So when it comes to what we're just discussing, this is irrespective of whether you use a Philips or an Olympus or whatever scanner you use. But this is currently, let's call it the rule set. So when someone asks, would you want to continue working under these regulations? I think what we're basically asking is this sufficient? Do we want more, or do we want to even have less than this? Because this is already kind of the bare bone minimum. No one is saying you can't diagnose DCIS remotely or anything. So we're already kind of, you know, not off the leash, but this is already relatively specific what we would have to demonstrate. So I would really want to hear whether the group thinks that that's okay, or do we want it differently, right? Would we say that we want a lot more or a lot less than what's currently being asked of us to do? And I know that that's a tough question.
Tough question. I mean, there's a lot here too, because the way Matt, thanks Matt for joining too. You know, I mean, we addressed it in the paper, but we didn't necessarily do it under this framework. But when you look at the check the box and all these different things, we did address that. But, you know, to specify at absolute granularity what, you know, things like specs on a monitor, you know, this is not addressed in this paper, and I'm not sure, that seems to be a rabbit hole that is hard to deal with. I think going back to my point in the chat, I said we can validate locally about what threshold we want. And if we're comfortable, we're also accountable for that. I think that's maybe the point I want to make without actually drilling into a specificity that becomes a mandate for every locality. I think that's the part that I think a lot of people feel uncomfortable because
Yes.
people have a hard time figuring that threshold. Some are a little more cautious, some are a little more flexible. That also depends on the pathologist, but in the end, accountability is probably left to the locality. And I think we could write it in such a way that the locality is accountable, but they sort of determine what they feel comfortable about in terms of what's the right bar.
Yeah, so I think, I second that. So, most of these requirements, is the specimen prepared right? Is it grossed right? Is it labeled right? Is the laboratory documents everything fine? And then, the retention requirements, I think are also fine. That is sort of a given. So I think what it comes down to, and what I think there's a lot of confusion about this under the enforcement discretion, it basically says, verify the performance of your test, which, I think as Matthew pointed out, if you serve up the image right, let's do it. Sam, I see you raised your hand. Sorry.
No worries. So the one thing I'm saying that might be useful to add to this is the idea of each site doing a risk assessment. I don't know if that's been talked about or not, where you do a risk assessment, where you ask these questions in a document. Can you differentiate between different findings of, benign and malignant breast or a prostate or whatnot, H. pylori, that sort of thing. Where you actually ask that question, do we need to see H. pylori? And then you actually answer that question, be like, no, we don't have to because it's mitigated by the immunohistochemistry assay, something like that. And it would be a long document, I know that, but it might be very useful to at least consider something like that. Because I know for, in quality, risk assessments are used a lot in these situations that aren't really, not necessarily regulated to a T of like, you have to do this and this and this and this, just that you assess the risk and thought of the risks and mitigate them as much as possible. And this would be, catered towards the specific site. And it's something that would be sort of like a living document, because it's something you just continuously do because you'll find new risks as you practice more. But it shows an active engagement of this idea of, this is new, and we are addressing it. This is something you show regulators that you are actively doing. No, it's not perfect. It's not gonna cover every single thing, but it does show an active process that your pathologists are making sure that they are.
Simon, let me just ask quickly and kind of half addressing what Douglas put in the comment. I don't know if you saw that, but would this risk mitigation in an ongoing process, wouldn't that fall under kind of like, how did you do proficiency and competency assessment? Because that's a requirement as well. So that would also apply to remote sites. So that part, by the way, is also accounted for in the current enforcement discretion. And, so are you asking or are you proposing to do something in addition to that? Or would you say that that would account for? So should remote sites...
it would be something in addition, and it would be done by pathologists that are, signing at home, because then you notice instances where like, oh yeah, I noticed this difference, is this something that's okay? And it's something you would discuss with other pathologists. And it's not, something that has to be done. It's not specific lines that have to be checked by everyone, but it's more like, oh, I thought about this. Oh, this might be actual risk that we're doing. Let's talk about with the group, and is this risk mitigated? Is this something we have to be worried about? Again, it's not, I know it's not a checklist, which would be nice, but for a lot of these things that regulators are looking at, they're just wanting some documentation that you are ensuring quality.
Yeah, that last part. Yeah.
So the question is, so I'm all for it. It should be less this a slide you showed. Sorry, I'm trying data learners, right? But the thing is, and I agree with your comment, Sam. But I don't know if you have discussed it before. So we have a validation that we do centrally at the headquarters or whatever the lab location. The question is, does it have to be, if I don't know if this has been discussed, as separate validation set at the location that pathologists sign out? Has it been discussed?
You mean?
So my point of view is the validation that we do before implementation, verification and validation we do, that should be enough for primary diagnosis. For if there's somebody wants to sign out cases remotely, I think the specifications of or QA practice comes to making sure that monitor is working properly. So obviously, if monitor doesn't have the color calibration, they can do it manually, but it should be done.
I think you're getting at a remote site validation, basically. So for,
So
let's say
what
you have 60 remote sites, then they should be validated in some way rather than a blanket one. Maybe that's what you're getting at?
Yeah, I'm saying the blanket one should be enough. Has it been discussed?
Not really, actually. This kind of ties in closely to maybe one of my concerns I bring up all the time. You know, one of the things, and yes, we're all, you know, big on the quality, but one of the models by being able to outsource, I always use the word Uberification. I want to make sure that, you know, there's enough quality assurance to ensure that Uberification doesn't happen. And namely also that if you can outsource, there's a downward pressure on salaries. So how can you sort of create a specification that ensures a certain level of quality by the remote site and prevents, let's say, a big company from just outsourcing all the jobs out there, and it doesn't really matter what that site's doing. They could be doing it off a laptop that has low quality and all these other things. So I think maybe what you're getting at sort of touches on a point that I'm also very interested in too. How do you do it without being too onerous? Because yeah, validating 60 sites is also one thing as well. So
yeah, that's not possible.
Yeah. So
so
yeah,
one thing that we did at the beginning of the implementation, we provided the digital, the glass slide. I'm talking about the consult portal we set up. It's kind of similar thing. For 2 months, doesn't have to be 2 months. Even we found out like 2 weeks, maybe it's enough to provide the, like having dual system for sign out. Looking at digital images, don't finalize, looking at the glasses slide and compare your diagnosis. Can kind of help our pathologists to feel confident and comfortable to just go by digital images. So, I mean, there are, but my point is that those specifications should be specified, and it should be less. And the current situation wouldn't work for remote sign out.
Oh, the current situation does work for that, because
the regulation are too many. I mean, we can the slide that you showed, I agree on.
They're fewer than ever, and a lot of people would argue that the public health emergency, as bad as COVID was, has definitely freed up some of the constraints. Sam, you raised your hand. Sorry, I didn't mean to cut in, but Sam, do you want to continue?
So yeah, no, I just I just wanted to kind of talk on the, you know, the, was it the on-site validation? Yeah, that is like, that would be kind of crazy, right? But again, if we just do something as simple as like a risk assessment for each site, filled out by the pathologist, and it could just be the initial time.
What do you mean by risk assessment?
It'd be like, can they look at the, well, it could be as simple as, can they look at the image and feel comfortable with making a diagnosis? I mean, that's like the overall question, right? And you can come up with different questions. Like, do you feel like your resolution is enough? Do you feel like you could see enough of the screen,
so how we, so that's exactly good question, but what I'm saying, that's how we evaluate that if they should feel comfortable or not, comparing with the glasses slide. And that kind of, that comparison helped. Even though we had validated the system, But
Mhm.
for short period of time, it's nice to provide them with like dual options side by
Mhm.
side, and they can see that,
Mhm.
oh, okay, I'm doing fine. I have no
Yeah,
problem.
yeah. And that's part of the risk assessment. And then you document that. Oh, wait, I looked at like this many cases and I feel
So we had
comfortable.
a different tab in the LIS. They would look
Mhm.
at the digital images because they would see the digital images first, and then it would take time for them to deliver the glasses slide. Under a
Mhm.
different tab, they would record, document the digital diagnosis, look at the glasses slide and finalize the report. And we would compare the finalized report with the diagnosis under that tab if there was any significant difference, which we didn't find any.
Yeah.
But
And,
again, two cases, minor details.
mhm. And I'm not proposing that you do that for every site, but make that available for anyone who is not comfortable at home.
So I agree that if you define the group, it defines the, I mean, pathologist, define the specification that's required for that risk assessment.
So let's talk quickly about something rather simple, which is one of the requirements that every temporary site should comply with HIPAA. Can I just ask the group who are doing remote sign out how you document it or how you assume that people use this other than relying on their professionalism? Does anyone have, let's say, a written document, or did they implement, hey, you shouldn't sign out at Starbucks, right? This is not necessarily
Oh, I
something
don't know.
directly related to, how you serve up the image or how it's scanned, but
I
this
like
is
what
a,
Harsh put in the comment there, because I mean, boy, we can go to the regulations to the nth degree and just bog ourselves down. But best practices, the separation between best practices and what the regs say, that's something too. Because let's say if there's a violation that happens, maybe it didn't necessarily hit the regs, but if you didn't meet best practices and you were signing out at Starbucks using the public Wi-Fi, even if you're using VPN, but it's visible, that's not best practices. And then that actually creates a case for potential, without actually having the onerous regs put on you. So maybe that was what you were saying, but I kind of like the idea of separating without making the regs too onerous, that you put out best practices out there. And, it ends up being that you get looked at if something bad happens, like, hey, you didn't follow best practices. And so by that way, you alleviate the regulatory, but you don't put it all on the regulatory people. You basically create a code of conduct. And if something goes bad, you didn't follow it, and somehow, somebody can civilly get at you.
I mean, there's two parts to this. Number one, so that would argue that the current enforcement discretion would be sufficient. So we would agree that making that permanent would be great. The second part is it's fine if we all talk as a happy family, but if there's a legal case and a physician or a pathologist is on the line for saying, hey, there was something wrong, suddenly there's lab director and local process versus, a professional opinion rendered. And those, let's say in a dispute case, it comes down to how did you document that you were compliant at a temporary site? So I'm not a fan of documentation, but when it comes to, what the regulations should and should not define currently, they just state that the temporary site complies with federal law, including HIPAA. That is a very broad statement that they don't specify. So I would say that's sufficiently broad so that it's mentioned, but it doesn't is not too prescriptive to say how are you ensuring, are you monitoring people and taping them where they sign out, or do they do IP tracking, right? Those are options nowadays. But so what I'm currently sort of lacking in this discussion is where do people disagree with what the enforcement discretion has enabled, where is it too weak and where is it too restrictive? And so far, I think everyone agrees with what has currently been proposed.
So I
Is that
think
fair?
people add disclaimers on their report. I mean, they can add disclaimers on the report. I mean, any LDT, I mean, typical lab testing, if you have an LDT, usually put a disclaimer on the report saying what the process was, or that it was LDT, that it was approved, and that, you've documented and done all your appropriate measures. And you have that documentation when you have your, accreditation bodies come and inspect. Again, that documentation is part of the LDT process, part of the QC process, part of, staff training. I mean, all the above, right? These are things that we do for every, daily tests that are involved in the lab, right? This is just another test that we're adding. So to be quite frank, it's almost impossible to know when a pathologist signs out remotely or not, right? If they're VPNing or they're accessing the LIS, they're reporting in the LIS, and my understanding is there's really no way to 100% concretely know whether a case was signed out remotely or locally at the hospital. And I would argue that if you did validate and you looked at non-inferiority or you documented equivalency, there really may not need to be a way to know that. So, and you have your disclaimer and you validated it, and your documentation shows that all your processes are up to date, your QC is available, that these are in theory just an additional test.
So I mean, Matthew, you went through this, and Joe, you as well, over 100 pages with New York State and as an LDT and complying with CLIA. So did you identify anything where you think that was a little too lax or a little too restrictive? I mean, let's not talk about the initial work, right? But because once the wheels are greased and people know how to do it, people will do it. I mean, did you notice?
We've had 2 inspections since that LDT was approved, and all of our documentation was reviewed, and it seems to be sufficient. We weren't cited for anything. Granted, this is probably a learning process for all the accreditation bodies, but it seemed like whatever documentation we were able to provide was sufficient to show that we were doing a good enough job to support the operation.
And I think
Nothing
bad happened too. Sorry, Matt. And I think that's the other thing. We're always worried about the worst case scenario, but that's the thing. Bad people, the light gets shed on certain things when bad things happen. And so, I mean, this is a new field, and obviously we didn't know, none of us are signing out at Starbucks, so we're not doing anything like it. So it doesn't give them a reason to look at it as hard. It will happen when it expands. And I know we're worried about this right now, but we're so early. And as long as people sort of abide by certain codes of conduct and understand that once something goes bad, that's going to open a door for us to get really, really regulated. There's a certain caution by the early adopters out there, in terms of doing things.
Harsh, you raised your hand.
Thank you. There is, this issue about whether we should have that disclaimer. There's the standard disclaimer, but we have a couple of different sites where our pathologists sometimes go to cover frozen, and we used to send slides to them so that they could still work there. And and those sites have different CLIA numbers. So we had to insert, if a pathologist provided that professional service while sitting at that other CLIA, then we had to set it up so that the IP address was detected, and the comment was inserted: professional services rendered at such and such site with CLIA number so and so.
Harsh, do you have that? Did you?
We do have that.
That would be a very, very important regulatory, meaningful data set. If you have like a fellow or so who would be willing to write this up, this would be amazing, because I have not heard of anyone who has a basically location-based documented process for, because you could compare that.
Yeah, it is for our CLIA approved additional sites. So, our stickler CAP accreditation person said we need to do this. The issue that I wanted to bring up, which is an esoteric one, which we may not want to get into, but it is a regulatory concern. If you are sitting in your home in New Jersey or Brooklyn, or even Brooklyn or Queens or some other part of the New York metro area, then actually the Medicare reimbursement rates are different. The geographic modifiers are different. So the problem is, if you render your professional services, then technically you should be billing and get reimbursed by the geographic region where you were a pathologist for that professional component. I hope no billing person figures this out, because it's going to be a nightmare to sort through that part of it. And that's not really a CLIA thing. It's CMS thing, so I don't know how that can be solved. I didn't want to bring up yet another issue, but this is, theoretically, an auditor might bring that up. So just wanted to throw it out there.
It's not based on privileges. It's
No, but
not
it
based
is.
on billing. I always thought it
It
was
is
based
important though, because we have another separate CLIA lab that we are now going through an additional validation for in the coming weeks. But it's an important point to call out because it would be under a completely separate CLIA number, CLIA license.
Anyone, any comments on proficiency testing or competency assessment in remote sites?
I mean, we do have another hour tomorrow to hash this out some more. I thought 3 was gonna be plenty, but I think this could be just going on and on and on. I don't know. What do folks think?
I would like to thank you guys, whoever organized this. I think that's a very good start point, and it should have been done earlier. So I'm glad that at least we started doing so. And I think we are, as practitioners, we are the ones who should define these specifications. So thanks to Dr. Lenners and Dr. Sarantarapan. Thank you very much. And others, whoever organized this. And I think it's going to take time, but I think it should be specified. I don't know what's the CLIA position on this. Have you reached out to them? Are they open to?
They're probably even listening. The idea is that this be public, and anybody who's on CLIA, for instance, that will be probably the voice. They can listen to this conversation. That's why I said this conversation is important. We throw out every idea possible. In the end, they advocate for what they see the direction. They're on those meetings, and but this is supposed to be educational to get them insight. And I'm sure they're probably listening to this. That's why I say these conversations are very, very important.
And
So
I'm all for
aim-
streamlining the process, but it should be defined and clarified. The code of conduct and whatever specification that the pathologists at remote locations should go through. Go ahead.
So we plan to put the results of this together, similar to other projects where people can put their name under it and agree or disagree and point. We do revisions just like normal, and that will be publicly available. I know CMS CLIA is waiting for input from all professional societies, but also from interest groups like these where, things can be discussed in a little more open manner. But thank you very much. And if you have time tomorrow, I'm looking forward to seeing you.
All right.
Thank you.
Thanks. Bye.
Bye-bye.